Welcome to the deep dive. Today we're tackling a really fundamental area in medicine, anticholinergic drugs.
Absolutely.
If you're following along with your studies, especially, those of you watching KMR Advise on YouTube.
Yeah, with the lecture discussion.
Exactly. This is core knowledge you really need.
It is. And these drugs, they just pop up in so many different contexts, don't they?
They really do.
From like getting someone ready for surgery to managing long-term illnesses.
Yeah.
Even critical situations.
Right.
Understanding their core actions is just key.
So our goal today is, well, it's straightforward but crucial. We're going to unpack anticholinergic drugs, how they work, why they're used in such a variety of ways, and importantly, what we need to be careful about.
Definitely.
And we're structuring this deep dive to align with the material you might be seeing on KMR Advise, kind of following that sequence.
That makes sense. And for everyone tuning in, particularly our KMR Advise viewers, if you find this helpful, please do share it, subscribe to the channel, maybe hit that bell icon.
Good shout, so you don't miss out on more educational content like this.
Exactly.
All right, let's dive right in then. Where are these anticholinergic drugs actually used? It's quite a list.
It is, yeah.
First up, pre-anesthetic medication. And the classic example here is atropine.
Right, atropine.
What's its job in that setting? Why use it before surgery?
Well, think of it this way. Before surgery, sometimes the body produces excess saliva, respiratory secretions.
Ah, okay. Which could be a problem during anesthesia.
Exactly. They can be problematic.
Yeah.
So atropine helps to sort of dry those up.
Got it.
And also, anesthesia can sometimes cause the heart rate to slow down too much.
Bradycardia.
Bradycardia, yes. And atropine can help prevent that or treat it if it happens.
That makes perfect sense. Okay, then we move to respiratory illnesses like COPD and asthma, where we see ipratropium being used. How does that fit in?
Well, with COPD and asthma, the airways can become constricted, tight. Right. Ipratropium is inhaled, so it works directly in the lung. Yes, locally. To relax those airway muscles. That leads to bronchodilation, makes breathing easier.
Okay. Next, a really common issue. Overactive bladder.
Oh, yeah. Very common. For that, medications like oxybutynin and toltergine are often used.
And how do they help?
They target the smooth muscle in the bladder wall, helping it to relax. That reduces those sudden urges, the frequency.
The main symptoms people complain about.
Exactly. Those frequent trips to the bathroom.
Right. Shifting gears a bit into neurology now, we see anticholinergics playing a role in Parkinson's disease.
That's right. A drug like trihexyphenidyl can be quite helpful.
For which symptoms specifically?
It helps manage some of the motor symptoms of Parkinson's, particularly tremors and the stiffness, the rigidity.
Oh.
It helps to sort of rebalance some of the neurotransmitter activity in the brain.
Yeah.
It's about the acetylcholine-dopamine balance.
Interesting. And who hasn't encountered scopolamine for motion sickness, that little patch?
Ah, the patch. Yes, quite effective.
How does that work?
Scopolamine is usually given as a transdermal patch. You stick it behind the ear, usually.
Right.
And that allows for a nice, steady release of the drug into the bloodstream over time.
And that stops the nausea.
It's very good at preventing the nausea and vomiting that comes with motion sickness, yeah.
It's amazing, really, how one class of drugs can have such diverse applications. We even see atropine popping up again.
Yeah.
In a very different and, well, critical situation. Organophosphate poisoning.
Yes, absolutely critical there.
Yeah.
In cases of poisoning with organophosphates, you find those in some pesticides.
Right. Nasty stuff.
Very nasty. Atropine is a life-saving antidote in those situations.
How so?
These poisons basically overstimulate certain receptors, the muscarinic receptors. They flood the system.
Okay.
Atropine steps in and blocks those receptors, blocks those effects. It's like hitting the brakes on an overactive system.
Okay. And finally, we have some procedural uses. Let's start with pupil dilation for eye exams.
Right. When an ophthalmologist needs a good look inside your eye, they'll often use tropicamide eye drops.
And that just widens the pupil.
Exactly. They dilate the pupils. That's called mydriasis, giving a much clearer view of the retina, the optic nerve, all the structures back there.
Makes sense. And for those dealing with the discomfort of irritable bowel syndrome, or IBS, there's dicyclomine.
Right. Dicyclomine can help ease the painful muscle spasms.
In the gut.
Yes, the spasms in the GI tract that are really common and, frankly, miserable for people with IBS.
Okay, so we've seen the breadth of their uses. It's really quite remarkable.
It is.
Now let's get into how these drugs are categorized. There seem to be a few different ways to group them.
That's correct. We can classify them based on where they come from, their origin, and also their chemical makeup.
Okay, like what?
So first we have the natural alkaloids. These are derived from plants.
Yeah, examples.
The main examples are atropine, often seen as atropine sulfate, and scopolamine. You might see that branded as scopoderm sometimes.
Got it. Natural alkaloids. And then we move on to the synthetic agents, drugs made in the lab.
Exactly, the synthetic anticholinergics. And these are further divided into two main groups based on their structure.
Which are?
Tertiary amines and quaternary amines.
Okay. Examples of tertiary amines.
Tertiary amines include drugs like oxybutynin, you might know it as Urotone, and trihexyphenidyl, sometimes called pacetane.
Right, and quaternary amines.
Quaternary amines include ipratropium, branded as ipraventofen, and glycopyrrolate.
And you mentioned brands. It's worth noting some of these, especially as our KMR Advise audience, perhaps in India, might recognize those local names.
Absolutely. Knowing the generic and common brand names is always useful in practice.
And there's one more category that might not immediately spring to mind, antihistamines.
Yes, that's an important one. Certain antihistamines, particularly the older first-generation ones like diphenhydramine.
Benadryl.
Benadryl, exactly.
Yeah.
They also have significant anticholinergic effects as kind of a side effect of how they work.
And why is that important to remember?
Because it can add up. If a patient is taking an anticholinergic for, say, bladder issues, and then also takes Benadryl for allergies.
You get additive side effects.
Precisely. It contributes to the overall anticholinergic burden, the total effect on the body.
Okay. Now, you mentioned this key difference between tertiary and quaternary amines. Something about the blood-brain barrier.
Yes, this is a really critical distinction. Absolutely vital to understand.
Why is it so important clinically?
Because tertiary amines, due to their chemical structure, their lipid solubility, they can cross the blood-brain barrier, the BBB.
Get into the brain.
Get into the brain, exactly. And this means they can have effects on the central nervous system.
Like what kind of effects?
Potential side effects like drowsiness, confusion, dizziness, even delirium, especially in older people.
Okay. And quaternary amines?
Quaternary amines, on the other hand, have a charge. They generally have much more difficulty crossing the BBB.
So fewer brain effects.
As a result, they tend to have fewer or less intense of these CNS-related side effects.
Right. So for our medical students following KMR Advise, this is a vital point.
Absolutely. Grasping this helps you predict potential side effects and choose drugs more wisely.
That makes a lot of sense. So for instance, if we're treating, say, a bladder issue with a quaternary amine.
Like glycopyrrolate, perhaps, though less common for bladder. But yes.
We might be less likely to see confusion as a side effect compared to using a tertiary amine, like oxybutynin.
Precisely. That's the trade-off you often consider.
And you also highlighted oxybutynin's high antimuscarinic activity earlier.
Yes, it's quite potent at blocking those receptors.
How does that relate to its use for urinary incontinence?
Well, if it's very good at blocking muscarinic receptors, and those receptors are heavily involved in causing bladder muscle contraction.
Then it's good at relaxing the bladder.
Exactly. It's effective at relaxing the bladder and reducing that urge to go, that incontinence.
But I imagine that high activity also means
a higher chance of those other anticholinergic side effects we've talked about, like dry mouth, constipation, maybe blurred vision.
Right, the anti-CELA-DG stuff.
Exactly right. Because oxybutynin is so effective at blocking those receptors, not just in the bladder but elsewhere too, it can indeed lead to a higher incidence of those broader side effects.
So it's always a balancing act, choosing the right medication for the patient.
Always. Risk versus benefit.
Okay, so we understand where they're used, how they're classified. Now, let's really dig into the nitty-gritty, the mechanism of action.
Right.
What exactly are these drugs doing at a cellular level?
Okay, so at their core, anticholinergic drugs work by blocking the action of a neurotransmitter called acetylcholine.
Acetylcholine, key messenger.
Key messenger, especially in the parasympathetic nervous system. That's often called the rest and digest system.
Right.
These drugs physically get in the way. They prevent acetylcholine from binding to its target receptors.
And these receptors we're talking about, those are the muscarinic receptors mainly?
Yes, primarily the muscarinic receptors. There are different subtypes, M1 through M5, found in various tissues.
And blocking acetylcholine there, what does that do?
By blocking acetylcholine at these muscarinic receptors, the drugs essentially dampen or inhibit the normal parasympathetic responses in the body.
Okay.
This leads to a predictable set of effects. And it's really helpful to remember these using that mnemonic Anti-cell DE.
Ah, yes, anti-cell DGE.
Okay, for our KMR-advised viewers maybe hearing this for the first time, let's break it down.
Sure. So S is for decreased salivation. That gives you the dry mouth.
Got it.
L represents decreased lacrimation, so dry eyes. U is for urinary retention, difficulty emptying the bladder fully. D can stand for drowsiness or sedation, especially with drugs crossing the BBB. Also dry skin sometimes. G refers to gastrointestinal upset, but specifically slowed motility, often leading to constipation.
And
E signifies blurred vision, often from eye effects like mydriasis, the dilation of the pupils we mentioned, makes it hard to focus up close.
So anti-salivation, lacrimation, urination, defecation, drowsiness, GI motility, emesis eyes.
Got it.
That's the essence of it. And it's worth noting, at very high doses, like in a severe atropine overdose, anticholinergics can even start to block nicotinic receptors too, not just muscarinic.
What does that lead to?
That can potentially cause neuromuscular blockade, muscle weakness, even paralysis, a really serious situation.
Okay, good to know. So by blocking these muscarinic receptors, we get this whole constellation of anti-cell DGE effects.
Exactly.
Now, what are the actual clinical effects we observe in different parts of the body? You mentioned some already.
Precisely. So in the respiratory system, blocking these receptors leads to bronchodilation.
Which is why ipratropium works for COPD and asthma.
Exactly. In the GI system, that decreased motility can actually be beneficial for treating conditions like diarrhea or the cramping in IBS.
Right.
Ophthalmically, the mydriasis, the pupil dilation, is what makes drugs like tropicamide useful for those eye exams.
Makes sense.
And in the central nervous system, well, it depends.
On whether it crosses the BBB.
Yes. If it crosses, like scopolamine, you can get sedation, which is useful for motion sickness. But in toxicity, like with atropine,
you mentioned agitation.
You might see agitation, confusion, even hallucinations. It really highlights how widespread the effects of the parasympathetic system are.
It really does. Okay, and finally, how does the body get rid of these drugs once they've done their job? Termination.
Good question. It varies. For atropine, it's primarily metabolized, broken down by enzymes in the liver.
Okay.
And then the breakdown products, the metabolites, are excreted by the kidneys in the urine.
And ipratropium, the inhaled one.
Ipratropium mainly exerts its effects locally in the lungs. Very little of it actually gets absorbed into the bloodstream. So the small amount that does get absorbed is largely eliminated unchanged in the feces, and some via urine too.
That difference in how they're cleared makes sense, considering how they're given and where they act.
Exactly. Form dictates function and pharmacokinetics.
Which brings us nicely to pharmacokinetics, how these drugs move through the body over time. Absorption, distribution, metabolism, excretion. The ADME.
Right, the timeline of action. Let's look at a few key examples.
Okay.
Atropine, if given intravenously, like in an emergency.
Yeah.
Very rapid onset. Usually within just a minute or two, you see effects.
Wow. Fast.
Very fast.
Yeah.
As he said, metabolized by the liver, excreted by the kidneys.
Okay, ipratropium.
Inhaled ipratropium has a slower onset, more like 15 to 30 minutes.
Right.
And because it mainly works in the lungs, systemic absorption is minimal. Most of what little gets absorbed is eliminated in feces.
Makes sense. Oxybutynin, the bladder drug.
Oral oxybutynin starts to work within about 30 to 60 minutes. It undergoes quite significant metabolism in the liver by an enzyme system called CYP3A4.
CYP3A4. That rings a bell for drug interactions.
Exactly. This is a key point for our KMR advised students. Oxybutynin levels can be affected by other drugs that inhibit or induce CYP3A4.
Good point. And then excretion.
Excreted mainly in the urine after metabolism.
Okay. Lastly, the scopolamine patch.
The patch has a relatively slow onset. It takes about 4 to 6 hours to really reach its full effect.
That's why you have to put it on early.
Precisely. It's metabolized by the liver, and then the metabolites are excreted in the urine.
Those details really highlight the clinical implications, don't they? The rapid onset of IV atropine for emergencies.
Crucial.
And that delayed effect of the scopolamine patch, explaining why you need to put it on before you travel, not when you start feeling sick.
Exactly. Planning ahead is key there.
This leads us nicely into clinical pearls, those sort of practical bits of wisdom.
Yeah, the things you remember on the ward.
What are some key ones for anticholinergics?
Well, one important one, as we just touched on, is advising patients using scopolamine patches for motion sickness.
Yeah.
Apply them several hours before you need the effect, ideally about 4 hours beforehand.
Good tip. Another one.
Another key point involves glycopyrrolate. It's often the preferred anticholinergic in the ICU setting.
Why is that?
When you need to, say, reduce secretions or block vagal reflexes during a procedure, but you want to minimize any central nervous system side effects.
Like confusion or sedation.
Exactly. Glycopyrrolate is preferred because it's a quaternary amine.
Doesn't cross the BBD easily.
Doesn't cross the blood-brain barrier to any significant extent. So you get the peripheral effects you want without the central side effects.
That directly links back to that tertiary versus quaternary distinction. Really valuable practical takeaways.
They are.
Now, of course, we need to discuss the potential downsides, the adverse effects.
Right. No drug is without potential side effects.
And with anticholinergics, there's a whole constellation of them, often called the anticholinergic toxidrome.
Yes, the toxidrome. And there's a really helpful, if slightly dramatic, mnemonic for remembering the classic science.
Which is?
Hot as a hare, blind as a bat, dry as a bone, red as a beet, mad as a hatter.
Okay, let's unpack that. Hot as a hare.
Fever. Hyperthermia. The body can't sweat effectively to cool down.
Blind as a bat.
Dilated pupils, mydriasis, and difficulty focusing, blurred vision.
Dry as a bone.
Dry mucous membranes, dry mouth, dry eyes, dry skin, no sweating.
Red as a beet.
Flushed skin, vasodilation.
And mad as a hatter?
Altered mental status, confusion, agitation, delirium, hallucinations.
Wow. That mnemonic really paints a picture.
It does. And it's important to recognize, in severe cases of this toxidrome, there's an antidote.
An antidote.
Yes, a medication called physostigmine can be used. We'll come back to that.
Okay. What about specific effects on the central nervous system, maybe not full toxidrome level?
Well, because those tertiary amines can get into the brain.
Right.
They can cause CNS effects like delirium, especially in older adults. They're more susceptible.
Makes sense.
And even hallucinations can occur. If these kinds of symptoms arise, and you suspect an anticholinergic medication,
what do you do?
the first step is usually to stop the offending drug, if possible, and see if the symptoms resolve.
Okay. And you also mentioned a potential eye-related complication earlier, glaucoma.
Yes, specifically angle closure glaucoma.
How do anticholinergics affect that?
The pupil dilation, the mydriasis that these drugs cause, can be problematic in individuals who have a narrow angle in the front of their eye.
Okay.
Widening the pupil can bunch up the iris and block the drainage of fluid from the eye.
Leading to a pressure spike.
Exactly. A sudden, dangerous increase in intraocular pressure. This is an emergency.
We do.
It requires urgent attention from an ophthalmologist. Immediate referral.
Got it. So, given these potential adverse effects, it makes sense that there are certain situations where using these drugs is, well, not recommended.
Or even outright contraindicated, yeah.
Let's talk about those contraindications.
Okay. We can think of them as absolute contraindications, meaning you generally should not use the drug at all.
Right.
And relative contraindications, where you need to be very careful and weigh the risks versus benefits.
Okay, what are the absolute ones?
Absolute contraindications for anticholinergics typically include angle closure glaucoma, because of that risk of triggering an acute attack we just discussed.
Makes sense. Anything else?
And also myasthenia gravis.
Why myasthenia gravis?
Myasthenia gravis is a condition where there's impaired signaling at the neuromuscular junction, leading to muscle weakness. Acetylcholine is key there.
Ah, so blocking acetylcholine further would worsen the weakness.
Precisely. It can exacerbate the condition significantly.
Okay, those are the absolute ones. What about the relative contraindications? When should you be extra cautious?
Relative contraindications include conditions like benign prostatic hyperplasia or BPH.
Enlarged prostate in men.
Yes. Anticholinergics can make it harder to urinate by relaxing the bladder, but potentially tightening the sphincter, or just reducing the voiding reflex.
Leading to urinary retention.
Potentially leading to acute urinary retention, which can be quite serious. So you use them cautiously, if at all, in men with significant BPH.
Okay. Any others?
Similarly, you need caution in patients with known gastrointestinal obstruction or severely reduced motility.
Because they slow the gut down further?
Exactly. They can worsen the obstruction or slow down the gut even more, potentially leading to a dangerous condition called ileus, where the bowel basically stops moving properly.
Okay. So really important to screen for these conditions.
Absolutely. A good history is key.
What about when anticholinergics interact with other medications a patient might be taking? Drug interactions.
Yes, several important ones to keep in mind. For instance, if you combine anticholinergics with other drugs that cause sedation, like benzodiazepines, some opioids, older antihistamines, certain antidepressants.
You get an additive effect?
Yes, you can see an additive effect, leading to excessive drowsiness, confusion, increased risk of falls, especially in the elderly.
Okay, what else?
Also, simply taking multiple medications that each have some anticholinergic properties, even if mild.
That additive burden again?
That anticholinergic burden adds up. The cumulative effect can become significant, leading to side effects, even if each individual drug seems okay.
Right. Anything else specific?
One more to mention. Anticholinergics can counteract the effects of metoclopramide.
Metoclopramide, that's used to speed up gut motility, right? Prokinetic.
Exactly. Metoclopramide promotes gut movement, while anticholinergics slow it down. They work against each other.
So using them together might not make much sense.
Generally not. Their effects would oppose each other.
That's a critical reminder about taking a thorough medication history. It's not just about the primary drugs.
Absolutely. Over-the-counter meds, supplements, everything counts.
Now, for our medical students listening, maybe prepping for exams, you had a specific exam tip related to toxicity.
Yes, a key point to remember, especially regarding the treatment of anticholinergic toxicity that involves the central nervous system, the delirium, the confusion.
Yeah.
Physostigmine is the antidote of choice in that situation.
And why physostigmine specifically?
Because physostigmine is an anticholinesterase inhibitor, it boosts acetylcholine levels. But crucially, unlike some others in its class, it's a tertiary amine.
Ah, so it can cross the blood-brain barrier?
Exactly. It can get into the brain to counteract the anticholinergic effects happening there. Others, like neostigmine, are quaternary and stay peripheral.
That's definitely a high-yield fact to nail down for exams. Great tip.
Glad to help.
Now, let's delve into some specific drug examples again, maybe with a bit more detail on dosage and clinical context.
Okay, sounds good. Let's start with atropine again.
All right. For bradycardia.
For treating symptomatic bradycardia, that's a dangerously slow heart rate, causing symptoms like dizziness or fainting.
Yeah.
The typical intravenous dose is usually 0.5 to 1 milligram.
Okay.
And that can be repeated every 3 to 5 minutes as needed, up to a total maximum dose, usually around 3 milligrams.
Got it. And for organophosphate poisoning, you said higher doses?
Much higher doses are often required there. It really depends on the severity.
Yeah.
But you might be starting with 2 to 6 milligrams intravenously. And repeating it frequently, sometimes every 5-15 minutes, until you see the excessive secretions, the drooling, the tearing, the bronchial secretions start to dry up. That's your endpoint.
Titrating to effect. Okay. What about oxybutynin for overactive bladder?
For oxybutynin, the typical starting oral dose for the immediate release form is often 5 milligrams, taken maybe 2 or 3 times a day.
And can you adjust that?
Yes, it can be adjusted upwards based on response and tolerability, often up to a maximum of maybe 20 or 30 milligrams per day, depending on the formulation. Extended release versions are also common.
Okay. And ipratropium for COPD? The inhaler?
Ipratropium, commonly administered via a meter-dose inhaler. Typically, the dose is 2 puffs 4 times a day. Nebulized forms are also used, especially in hospital.
Got it. And you had a specific note regarding scopolamine in kids.
Yes, a pediatric note. It's generally recommended to avoid using scopolamine, especially the patch, in children under the age of 12.
Why is that?
There seems to be a higher risk of central nervous system side effects, like confusion or hallucinations, in this younger age group. So caution is advised.
Good to know. Okay, let's talk a bit more about what happens in cases of actual toxicity and how it's managed. We touched on the anticholinergic crisis and the mnemonic.
Right, the hot as a hair. Mnemonic gives you the signs if you recognize that toxidrome.
That's the management.
The main specific treatment involves administering physostigmine intravenously, as we discussed.
The antidote that crosses the BBB.
Exactly. Typically a dose of 1 to 2 milligrams given slowly IV for adults. But crucially, you also need supportive care.
Like what?
Managing the hyperthermia with cooling measures, managing agitation, monitoring vital signs, urinary catheterization if there's severe retention.
Right, treating the symptom.
Treating the symptoms and providing overall support while the antidote works and the drug clears.
And if someone were to overdose specifically on scopolamine, does that look different?
Scopolamine overdose can be particularly noted for prominent symptoms like vivid hallucinations and significant agitation.
So the mad as a hatter part can be really pronounced.
It can be, yes. In these situations, while physostigmine might still be considered, if appropriate, Managing the agitation is key.
How do you do that?
Medications like benzodiazepines, such as lorazepam, can be very helpful to calm the patient down and manage the agitation and anxiety.
Okay, now let's shift to some important considerations for longer-term use and some key warnings associated with these drugs. Black box warnings.
Yes, there are some significant warnings and key notes that everyone, especially those prescribing or managing these meds, needs to be aware of.
Yes.
A big one relates to long-term use of anticholinergics in elderly patients.
That's the concern.
It's been linked to an increased risk of developing cognitive decline, dementia, and delirium.
That's serious.
It is. Because of this, it's generally advisable to avoid their long-term use in older adults if other effective alternatives are available. Really weigh that risk.
Is any specific drug more implicated?
Well, the overall anticholinergic burden matters most, but oxybutynin, for example, is often cited as having a high anticholinergic burden and has been associated with cognitive decline in some studies.
So be extra cautious with oxybutynin in the elderly long term.
Yes, careful consideration and monitoring are needed.
Any other key warnings?
One specific one relates to ipratropium inhalers.
Yeah.
They often contain soy lecithin as a propellant or additive.
And why does that matter?
Because soy lecithin can cross-react in individuals with a known peanut allergy.
Ah. So ipratropium inhalers might be contraindicated in peanut allergy.
Yes, that's a crucial contraindication to remember. Always check the product information.
Wow, those are really critical points, especially the dementia risk in the elderly and that peanut allergy link.
Definitely things to keep front of mind.
You also highlighted a really high-yield fact earlier, worth reading maybe.
Yes, absolutely. It's fundamental medical knowledge, really. Atropine is the first-line treatment for patients experiencing symptomatic bradycardia.
Slow heart rate causing problems.
Yes,
Okay.
and also the primary antidote for individuals suffering from organophosphate poisoning.
Core knowledge for emergencies.
Absolutely core knowledge. Critical point.
Okay. And to bring everything together, especially for our medical students listening to this on KMR Advise, maybe getting ready for exams, you've put together a concise final exam checklist.
Exactly. So to your quick review, the must-knows before you face questions on anticholinergics.
Let's run through it. Point 1.
First, make sure you understand the mechanism of action, MOA. It's all about blocking muscarinic receptors,
Leading
to those anti-cell DGE effects.
Yeah.
Know what they are.
Okay, second point.
Know the key drugs and their primary uses. Think atropine for bradycardia and organophosphate poisoning.
Right.
Ipratropium for COPD. Oxybutynin for overactive bladder. Those are the big ones.
Got it. Third.
Be familiar with the major contraindications.
Right.
Remember, angle closure glaucoma, myasthenia gravis, and be cautious with BPH.
Okay, fourth point.
Remember the antidote for central nervous system toxicity.
Physostigmine.
Physostigmine, exactly, because it crosses the BBB.
And finally,
Understand the key clinical pearls, especially the difference between tertiary and quaternary amines regarding CNS penetration,
yeah.
and be able to recognize the signs and symptoms of the anticholinergic toxidrome using that mnemonic.
Hot as a hare, blind as a bat.
Dry as a bone, red as a beet, mad as a hatter. If you've got those 5 points down, you'll be in pretty good shape.
Excellent checklist. And for all our KMR Advise viewers.
Yeah, maybe share this rundown with your study groups that covers the essentials.
Fantastic. This has been a truly comprehensive deep dive into the world of anticholinergic drugs. Really useful stuff.
Right, that was helpful.
We've covered their really wide range of uses, the underlying mechanisms, and those super important considerations for using them safely and effectively, especially with our medical students and healthcare professionals in mind, those following along with KMR Advise.
And as we've discussed throughout, it's just so vital to always consider that balance, isn't it?
The risk versus benefit.
The potential therapeutic benefits versus the risks of side effects, especially when thinking about factors like, does this drug get into the brain?
Right, the BBB penetration.
And what's the overall burden of anticholinergic effects, particularly in more vulnerable patient populations?
Like the elderly.
Exactly. It requires careful thought.
That's a really crucial final thought. For everyone listening, and especially our KMR Advise viewers,
Yeah.
I really encourage you to think about this balance in different clinical scenarios you encounter. How do you weigh those pros and cons for each individual patient?
It's a skill.
It is. It's a skill that really develops with understanding the pharmacology, yes, but also with clinical experience.
Well said. And if you found this deep dive helpful and informative for your studies or your practice,
Please do.
please make sure to like, share, and subscribe to the KMR Advise YouTube channel.
And hit that bell icon.
And hit the bell icon, yeah. So you don't miss any of our future in-depth medical explanations.